Okay, so we are going to continue with our slideshow about, in the lecture about voice production. So actually I want to leave that kind of there. And we're going to watch a video about how, just showing you how voice is made or sound is made through your vocal cords.
Feel singing is a great mystery.
This guy's kind of a goofball.
They don't understand how their voice
And this
works,
is singing based, but he does a good job of explaining how it
what's involved
works.
with singing. It all begins with the vocal cords. Specialists look at your vocal cords with a flexible or a rigid scope. The flexible scope is a small cord with a camera at the end of it. It's inserted through the nose and extended down the throat to see the vocal cords. The rigid scope is like a large pen with a camera at the end. It's used looking into the mouth and throat. Both images look like this. This can be confusing because the vocal cords are horizontal in the throat, like this. They are not vertical, like this. When the scope sees the cords and projects it on a monitor, they look like they're vertical or up and down. Vocal cords, sometimes called vocal folds, are located in the mid portion of your neck, about halfway down, between the top and the bottom of your neck. There are two vocal cords, and they're connected in the front of your neck and open and close in the back, or towards the back of your neck. They're located inside the voice box, or larynx. The cords sit at the top of your windpipe, or trachea. Men can feel the top of their voice box, often called the Adam's apple. Women have the same thing, but it's smaller and harder to feel with your finger. Your vocal cords are just behind the Adam's apple. Now, women can sometimes feel their Adam's apple by placing their finger here and gently pushing in on their neck. And about the first lump that you feel is the top of the larynx. About halfway down your neck, you can feel that small bump. That's your Adam's apple, ladies. And your vocal cords are just behind it. I can feel a small V right in the center of the top of my Adam's apple. That's the cartilage. Now, at birth, our vocal cords are about the same length, approximately 2 millimeters. By age 20, women's cords are about 10 millimeters and men's 60 millimeters in length. The change for men is much greater, and this causes a deepening of the voice and can make singing during the vocal change much harder. Vocal cords are tissue and are three-dimensional. That means they have length, width, and depth. Just like other tissue in your body, there are different layers of tissue. Vocal cords have three primary layers: muscle, ligament, and mucosa. It's the slick outer layer of the vocal cord. The vocal cords open when we breathe and come together when we make noise with our voices, and are covered up when we swallow. A type of lid called the epiglottis closes over the vocal cords when we swallow. Sometimes fluid gets through and we cough to clear it out. When air passes through our vocal cords as we speak or sing, they create a series of sound waves, which we can hear. This series of sound waves we call vibration. The vocal cords create the initial vibrations, which is the initial tones we hear that begin the sound we make, speaking and singing. Now watch and listen as these vocal cords create the vibrations that become our voices.
So, oh, there's the epiglottis right there, you can see.
Do you know your vocal type?
So that guy, who looks remarkably like Mr. Pelletier from the auditorium, does he not? Is don't like and subscribe because he'll never leave you alone. I made the mistake. So that is voice production. I think that, except for the corny background music, has a lot of good good concepts behind it and is a nice review. So, and usually that grosses me out, but there you are. Okay, so let's move on. So after the larynx, you end up, and the epiglottis, you end up with the trachea. So the trachea is made out of the first inside layer, and this was in the video, is the mucosa, which is that ciliated pseudostratified columnar epithelium with goblet cells that we talked about in the last presentation. And that's here, it's that respiratory layer. Below that is a submucosa area that is connective tissue. Oops, let's get rid of this. See it? And it has connective tissue and blood vessels, which of course you now understand is also connective tissue. And then there's the hyaline cartilage rings, which you hopefully remember from a million years ago. So mucosa, submucosa, and the hyaline cartilage part is called adventitia. I would much rather that you understand what the tissues are than remember the mucosa, submucosa, adventitia. I would go so far as to say that you don't need to know that. Now we're going to start talking about muscle. All the muscle we're going to talk about is smooth muscle. But in between the hyaline cartilage is C-shaped, so it would move up like this. And here, and in the back part of it, and in between it, you would have some smooth muscle. The smooth muscle can condense and help move, constrict, and when it does that, it causes air to come out faster. But as we keep moving down the respiratory tract, you will have like more and more interaction with smooth muscle, and we'll talk about how that affects people, particularly with asthma. All right, so now we enter the area that you call the bronchial tree. So the trachea comes down, here's the trachea, and it branches into two bronchi. And then from bronchi, it goes to bronchioles and alveoli, and we'll talk about that later. However, there are two parts of it. There's a conducting zone, which means that it's not doing anything physiological. It's just bringing air to the alveoli. And then there's a respiratory zone where gas exchange occurs. So we're going to start with the conducting zone, and it starts with the bronchi. You have a right one and a left one. The left one is longer because it overshoots the heart, which lives here. And then from there, it branches into lobular bronchi or secondary bronchi, and both are correct. There are 3 on the right, 1, 2, 3, and there are 2 on the left because you have 3 lobes on the right and 2 on the left. And again, these are patients' rights and lefts. After that, they branch, and every branch off of the every direct branch off the lobular bronchi is called a segmental or tertiary bronchi. And then it just keeps going. Like everything that branches off a tertiary bronchi is a quaternary or fourth order bronchi. Everything off of a fourth order bronchi is a fifth order bronchi. Sixth, anything branching off the fifth is a sixth order, and so on. It goes to 23rd order or until you reach a specific size. So once they get to 1 millimeter in diameter, which is very small, you start calling them bronchioles, which really, of course, as you know by now, means little bronchi. And then terminal bronchioles are half that size, so 0.5 millimeters. So if you have a terminal bronchiole, it's just incredibly tiny, and it's going to start having alveoli on it. And we'll talk about what that means in a second. So as your bronchi move from the primary bronchi down to, the 23rd order bronchi, the cartilage moves away, so the rings turn into plates. You still have some rings in your bronchi, but it turns into plates, and those plates become smaller and smaller and smaller as they move away from the trachea. And then the epithelium is going to go from pseudostratified columnar to just plain old columnar to cuboidal. And there aren't going to, the cilia and the mucus producing cells in the bronchioles are going to go away, because you don't want to make mucus. The mucus is a product, is the whole point of the mucus is to capture anything that you inhale. And if you haven't captured it already, you don't want to have fluid in your lungs. That's what pneumonia is. So you want to kind of keep that out, so that you don't want to have any goblet cells down in there. So now you just have smooth muscle, and you have more of that as you go. Cartilage, which is decreasing, and cells, which are getting flatter. So the cells get flatter, and this would be a great question on an exam, like to just explain the change in cells or in tissue types. So you have cartilage, which is going away, epithelium, which is going from pseudostratified columnar to cuboidal, and then eventually it's going to be simple squamous in the alveoli. So they're just getting, the cells are getting flatter and flatter. And then the smooth muscle is going to increase, because by the end you're going to end up with just smooth muscle. All right, so that was the conducting zone, and so now we're in the respiratory zone, where you have alveoli, and at alveoli you have gas exchange happening. So that's why it's called the respiratory zone, because it is functional. So at terminal bronchioles, you start having alveoli, just like little ones on the edges of them. And then they branch out into these alveolar sacs that have like all these alveoli on them that are like bunches of grapes. So there are these alveolar ducts, which are a little bit smaller than respiratory bronchioles, and they are made completely of smooth muscle and the connective tissue that's holding it together, and then the alveoli, which are simple squamous epithelium that are on the end of them. And so the deal is that as you have more smooth muscle, when you have asthma, what happens is that smooth muscle constricts and gets tighter. And it causes people who have asthma, and I have a daughter who has pretty serious asthma. It's like trying to breathe, but somebody just puts a drinking straw in your mouth and you have to breathe through that drinking straw. It's very limited. People talk about their chest feeling tight. And what happens is that these bronchi and bronchioles and alveolar ducts are getting very small. That smooth muscle is not relaxing. The albuterol that you inhale, which is what your rescue is in your rescue inhaler if you have one, those are going to constrict they're going to cause that constriction, and they're going to cause that muscle to relax, and that opens up your airways, and allows them to, air to flow in a sort of normal fashion. So at your alveoli, you have gas exchange. So the simple squamous epithelium is made of respiratory membrane, or that's what we call it. And you have about 300 million of these alveoli in your lungs, so it's a huge amount. And the surface area, because they're so, bumpy, is enormous. So the respiratory membrane is, again, simple squamous epithelium, something you should definitely know. These are also sometimes called type 1 cells, and there's almost no basement membrane between them. There's just enough to hold the cells together. They're like 0.5 microns thick, so ridiculously thin. So gas exchange can happen through diffusion. So a good thing to remember is that it's diffusion. So as long as you have less oxygen, here we're looking at the air side and the blood side. As long as you have less oxygen in your blood, oxygen will diffuse in because the membrane is so thin. And then as long as you have less carbon dioxide in the air side than you do in the blood side, the carbon dioxide will just hop out. There are a bunch of different mechanisms for this that I think we're going to skip over. But diffusion is the primary. There are a couple other movers of that. All right. In addition to that, you have these type 2 cells, which are cuboidal cells, and they make a very important liquid called surfactant that makes the alveoli a little bit wet enough for gas exchange to happen. So it can't really be dry. It wouldn't work. So this is sort of like a remnant of the fact that we were all waterborne creatures, evolutionarily speaking, a million years ago. Not a million years ago, millions of years ago. So oxygen is going to move back and forth through there. But the surfactant is something that is important, particularly in fetal development. Babies who are born very prematurely, their lungs haven't started making surfactant yet or making it in sufficient quantities, which is why babies need pure oxygen. I'll often see preemies with little oxygen tubes stuck up their noses because this lung development hasn't happened, and their lungs are developed. It's the surfactant production that's not happening. So that's an important developmental thing that happens towards the mid-20s weeks of gestation, and it's an important thing that happens. And after that, they're making surfactant. Premature babies are much better off when they are delivered. All right, other things. So you have a bunch of elastic fibers, and that's an important part for making it very think about that your lungs swell and then they decrease, and that's really important. You have these alveoli pores, which you can see here, and you could see in, don't freak out, I'm going to go back to this side. There are all these alveolar pores, and that makes it so you don't overfill them. They are little balloons. You wouldn't want to overfill them and let them explode. That would be bad. And then you have a whole bunch of macrophages. Anything that gets inhaled and gets all the way into your lungs, you want your macrophages there to kill that, or any infected cells, something like that. Incidentally, they think that in COVID, it's not really the virus, it's people having like a really heavy immune response to it. So we shall see, but that's an interesting sort of, I don't know, dynamic. So fun fact that there is no way to get rid of these macrophages. This is a fairly closed system, but they are very lightweight, so they are grabby onto the alveoli when they're alive, but when they die, they let go, and then your breasts sort of exhale them out, and they are swept up into your throat where you exhale them or you swallow them at a manner of 2 million per hour, and I have contributed ick to that because it's kind of icky. All right, let's go on and talk about the lungs. Just generally speaking, the anatomy. There are, as I said before, 2 lobes of the left lung to make room for your heart, and 3 lobes of the right side of the lung. You have a superior, a middle, and an inferior lobe, and the place where they attach to the bronchi is called the root. And they're sort of in little quadrants called lobules, which you can see here. They're kind of like, they're more or less hexagons, and they're served by they're all the alveoli served by like one large bronchiole. Remember that you have the pleural membrane that's over this. And then in between it, there is this tissue called stroma, which is connective tissue. And when you inhale particulate matter, so here, you see that can get caught in that stroma area. And so that's kind of, and you might think that this is a smoker's lung, but really this is the lung of like somebody who lived in a city or had a job that made had them inhaling a bunch of particulate matter, but living in a city would be, have your lungs like this. People who smoke have like truly black lungs. It is much, much more severe than this, but it starts in the stroma there. All right, so the lungs meet up closely with your pulmonary circulation, right, that we just learned about. So you have pulmonary arteries that are going to bring deoxygenated blood to the lungs. We talked about that last chapter. And that branches into pulmonary capillaries, which you can see here. These are the alveoli, and then you can see the pulmonary capillaries like sort of all around them like a net. And that's where oxygenation happens. Then you have pulmonary veins that are going to bring the oxygenated blood back to the heart. And then the bronchi need their own arteries, so they have these bronchial arteries that shunt some of that oxygenated blood off and takes it to the actual tissue of the lungs, because that tissue is tissue that is living tissue that needs blood as well. All right, in addition to this, you have 2 layers of connective tissue on top of it. Of the lungs, you have a visceral pleura and a parietal pleura, and you have fluid in between all of these, and it makes it very slippery and makes it so there is no friction. And the no friction is important because can you imagine running if there was friction? There is a disorder called pleurisy, which causes inflammation of the pleura, and when that happens, it causes just a lot of pain with breathing, like a lot of pain with breathing. And you get that usually from either doing some sort of contortionism, yoga, it comes to mind, or playing in some sort of contact sport where you get hit in the chest. And that can happen. All right, I think we're going to end this lecture here and pick up and do the last one in its own segment.